Okay, I'm going to go ahead and get us started. I know that folks can continue to join. My name is Caitlin O'Connell. I am happy to be joined today by Dr. David Schidlow and Dr. David Hoganson. We're going to be speaking to you today about cardiology and heterotaxy and setting the standard for heterotaxy care. Dr. David Schidlow is the co-director of the Heterotaxy Program. He's also a pediatric cardiologist at Children, so he'll be speaking to us about defining heterotaxy, as well as the cardiac manifestations of heterotaxy. Dr. David Hoganson is also co-director of the Heterotaxy Program at Boston Children's. He'll be speaking to us about the cardiac surgical care and special considerations for this population. I will then be speaking to the group about the Heterotaxy Program at Boston Children's Hospital, and then we'll save some time at the end for questions. So thank you all for joining us, and I will hand it over to Dr. Schidlow to get us started.
Well, thank you for that introduction, and thank you to the Benderson Family Heart Center at Boston Children's for facilitating this cardiac conversation. It's always exciting for David, myself, and Caitlin to be able to share with this community how we think about and provide care for children and families that are affected by heterotaxy. I have no disclosures. And so anyone familiar with the topic of heterotaxy in any way knows that this could very easily be a multi-day conference with numerous specialists, and something that we have done recently. But I am going to keep this relatively focused, and for my portion of this conversation, I'm going to discuss the following three topics. The first will be how we define heterotaxy, which can sometimes be challenging. I'm going to review the heart differences seen in heterotaxy, and I'm going to briefly address one of the key questions that comes up in heterotaxy, and that is comparing single ventricle palliation and biventricular repair in heterotaxy, which hopefully should be a nice segue into Dr. Hoganson's portion. So to start, how do we define heterotaxy? To define heterotaxy, one really first has to talk about the usual asymmetry that's found in the human body. So specifically, some organs are usually on the right side, and some organs are usually on the left side. So for example, the liver is usually on the right, and the stomach and spleen are usually on the left. When you're looking at this picture, you want to be pretending as though you're looking directly at somebody. Now, some organs do sort of cross the midline, but when they do, they usually have distinct right and left sides. So here we see that's the case with the lungs, and here we see the cardiac filling chambers have a distinct right and a left side. In heterotaxy, basically it means, and this comes directly from the Greek, it's another arrangement. So in heterotaxy, the body does not have the usual positions of organs within the chest and the abdomen, and the body takes on more symmetry than it usually has. And what happens is we get sort of a duplication of either the right side or the left side, and this is very frequently associated with differences in the spleen. So this could be the presence of a spleen or absence, the number of spleens, one or many, and then the location of the spleen. And in the broadest terms, what we have with heterotaxy are two sort of broad groups. Those that sort of tend toward two left sides, which we call polysplenia. So the spleen is the left-sided organ, so you can think of polysplenia as polyleftia. And on the right side, when there's duplication of the right side, we call that asplenia. Now, some centers will call this left atrial isomerism and right atrial isomerism respectively, but I'm going to use polysplenia and left isomerism interchangeably, same for asplenia and right isomerism. So when we do have that unusual symmetry, again, we have this sort of duplication. So we have sort of two left sides of the lung, one on the left and one on the right. And with the atria, again, those filling chambers of the heart, again, there's sort of a duplication of the left side. And then we have the, on the right side, or the asplenia, there's sort of two right sides and two right-sided filling chambers. I put sort of the abdomen in the middle here because that does tend to be more variable. We have a liver that often crosses the middle. The stomach really can be on either side, and the spleen can be a bit of a crapshoot as well in terms of where you would find that. And so how do we actually define heterotaxy? Well, to reach the definition of heterotaxy, we say that a minimum of 3 out of 8 features in the different organ systems need to be reached to count as having heterotaxy. And this is a reasonable list, although there are some drawbacks to it. It's very easy in some instances to sort of double up on certain criteria, but it's what we have for now, and it seems to work reasonably well. But more important than the location of different organ systems in heterotaxy is really that there can be significant functional abnormalities as well. And this can extend to the lungs, the spleen, the intestinal contents and their position, but this is a cardiac conversation, so I'm largely going to focus on the heart, and then Caitlin a bit later will tell you about sort of our multidisciplinary approach. So for these next few slides, I'm going to go over specifically the things that we see in the heart, and I'm going to go through asplenia, and then I'm going to go through polysplenia. And when we think about the heart, what we have is that there are certain differences that are more likely to occur in the asplenia type of heterotaxy than the polysplenia type of heterotaxy. And what I'm trying to do is to sort of break it down here. So we have the inferior vena cava, the pulmonary veins, the inflow or AV valves, the ventricles, the great arteries sort of leaving the heart, and the heart rhythm. But I realize that most of the folks on this conversation are not cardiologists, so I'm going to sort of translate it a little bit, and I'm going to point out the sort of really key differences that help us identify polysplenia versus asplenia. And that's not just academic, not just for us here at Boston Children's and Harvard Medical School, but it can be a key indicator as to not only things that might go on in the heart system, but in other organ systems throughout the body. So sort of helping us characterize this can be important. So for lower body drainage in polysplenia, that's often rerouted. For lung drainage in asplenia, that's often rerouted and sometimes blocked. The inflow valves in asplenia, oftentimes there's one shared valve instead of the normal 2 valves. In terms of the pumping chambers or the ventricles, in asplenia, one is often underdeveloped. We're a little bit more likely to see 2 well-developed ventricles in polysplenia. In terms of the outflow pipes or arteries from the heart, in asplenia, they are often switched in position, and the lung pipe is often blocked. In contrast, in polysplenia, sometimes the body outflow is blocked. And then in heart rhythm, so this is the cardiac conduction system, in asplenia, sometimes we have doubling of the heart rhythm, which causes an unusually fast rhythm. And in polysplenia, we have an underdeveloped or absent heart rhythm, which can cause an unusually slow heart rhythm. So just to say this is very important is that there's a lot of overlap between the 2 categories. So a very detailed anatomic assessment is crucial for every patient who has heterotaxy. So what you're going to see on the next few slides are just some examples of how things look when the heart is put together. So in asplenia, you remember I said that there's often differences in the lung drainage. Usually, here we have normal or the usual arrangement on the right side. The pulmonary veins come to the left atrium. In asplenia, they are often completely rerouted. Here, this one is going down below the heart and has to come back up through the liver. And unfortunately, what can sometimes happen is there can be severe blockage here, and this can be a big problem in patients who have asplenia. Moving on, atrioventricular canal defects, or sort of that single atrioventricular valve, are very common in heterotaxy. So here you see in the usual heart, there are two separate inflow valves, and here's a common valve, and this allows blood also through a ventricular septal defect to cross into the lungs and cause too much pulmonary blood flow. This is an example here on the left of that double outlet right ventricle, when the great arteries, those two big blood vessels, are coming off of a different position than usual. And we can see that the outflow to the lungs here is somewhat blocked as well. Switching gears over to polysplenia, and these are some of the key features we see. So I mentioned here on the right, we have the usual, the inferior vena cava, bringing the blue blood back to the right side of the heart. There's often this rerouting where the part of the inferior vena cava is missing, and instead this vessel called the azygous vein carries that blue blood into actually the superior vena cava. And also I mentioned that sometimes there's systemic outflow obstruction or underdevelopment of the pathway to blood flow to the body. So here we can see that the left side of the heart is small, with a small passageway out to the body, a small aorta. I also mentioned the heart rhythm. So normally the heart rhythm starts at the top of the heart and through electrical wiring goes through the top chambers, makes a pit stop in the middle, and then very rapidly goes to the rest of the heart. In asplenia, or right isomerism, there can be this duplication of the heart rhythm system. And in polysplenia, it can actually be absent or underdeveloped. And the result here is that there can be tachycardia in asplenia, where the heart rhythm just goes round and around, this duplication of the heart rhythm system. And in polysplenia, there can be what's called heart block, or a slow rhythm, which could eventually require a pacemaker, sometimes as early as the newborn period. Now, you know, all the things that I've gone through in the last few slides, one could go so far as to say are relatively commonly encountered among those who care for children with congenital heart differences. But what makes heterotaxy unique is the combinations that can occur. So oftentimes it's not just one of these things, but multiple put together. So for example, in asplenia, it's not uncommon to see dextrocardia with an AV canal defect and double outlet right ventricle, and maybe one ventricle is small, and maybe there's blockage to the lung blood flow, and maybe there is a fast heart rhythm. In contrast, in polysplenia, we might see that interrupted inferior vena cava. We may see blockage to the systemic outflow or the body flow. And we can see that heart block, the heart rhythm disturbance that I just mentioned. And this sort of leads us to the next question, which I think comes up very frequently. Many families from the region and from across the country and even internationally will reach out to Boston Children's asking, in heterotaxy, should we be thinking about single ventricle palliation or biventricular repair? And it's not uncommon to hear, well, what's the best approach? But I think really the question we need to be asking is, what is the right approach for a specific patient? And this is, frankly, another topic that could be a 2-day seminar. But you know, just to boil it down to its essence, when we say single ventricle palliation, we're basically saying that the heart is so complex that repairing and creating a heart that's maybe a bit more physiologically normal is so challenging that what we're going to do is we're going to reroute the blood flow and leave the chambers that sort of did form relatively normally to do the harder job of pumping blood to the body. Or in contrast, do we think about a 2-ventricle repair where we divide the heart and create 2 pumping chambers and maybe something that's a bit more physiologic? And so when we think about Fontan palliation, again, that's where we have that single pumping chamber. what are the potential benefits versus the drawbacks? This is a well-known pathway. Spontan care is improving. It's less surgery inside the heart. The drawbacks, it's multiple operations. It is not physiologic. We can run into Fontan blockages or even leaks. There can be some issues that occur because of high pressures in other organ systems. And frankly, because of heterotaxy, this just might be more anatomically challenging, and it might be a challenge with coexisting non-cardiac issues. In contrast, for a biventricular repair, again, the goal here is to have one pump pumping to the body and another pump pumping into the lungs. This is more physiologic. It's closer to the usual blood flow. And we have the two pumps. Potentially, there's lower liver pressure. What are the potential drawbacks? Well, this may require multiple surgeries. It may be a longer recovery. Reoperations may be needed, and we can run into heart problems here. And if we ever need to think about transplant, it could conceivably be more complicated. And so it is difficult, if not impossible, to make blanket statements about single ventricle versus two ventricle. Really, what we need to do is do a very careful assessment of each patient and determine what is the best possible path forward for that patient. For some patients, that's going to be a single ventricle palliation. For others, creating a physiologically more normal circulation is going to be a great path forward. But in either case, a careful assessment and careful discussion with a surgeon is absolutely essential. And that is a perfect dropping off point to let my colleague, Dr. Hoganson, take over. So thank you. Here's my contact information. This will be recorded. You can feel free to reach out at any time.
Yeah, so I'm going to sort of build off of what Dr. Schidlow was sharing and talk about how we're using some advanced planning approaches for our heterotaxy patients, including 3D modeling and flow simulation, to decide which is the best operation and how to go about doing that. So we do use a lot of engineering software and partner with several companies to do these analyses. So really the approach that we've taken in some of our more complex patients is to use CT scans or MRIs to create models of the patient's individual anatomy that are three-dimensional models that are engineering quality and then can be used to really enhance how we plan and conduct these operations. And so this is a process that starts with a CT or MRI, and then we have a team that creates these 3D models, and then that really serves as a platform for how to do advanced planning. So we often will use the models for evaluation of the anatomy before surgery and then in the operating room for intraoperative guidance. And then we can also use them to do advanced planning, such as patches or other reconstructions. And then particularly for our patients who have complex single ventricle physiology, as Dr. Schidlow was sharing, we can actually simulate the flow through the heart and then really understand before surgery which is the best option for some of these most complex patients. So it's really been a wonderful tool that we've advanced over the last 7 years here at Boston Children's. We've applied it to many of our heterotaxy patients. So this is an example of a three-dimensional model that we made for a patient with heterotaxy syndrome. They have asplenia and dextrocardia, and they just have a lot of anatomical features, including two vena cava and those anomalous pulmonary veins that Dr. Schidlow was talking about, as well as narrowing of the connection of the right ventricle to the outflow. And so you can see how rich of information these 3D models give us as far as we think about how the different elements of the anatomy are related to each other, both inside the heart and outside the heart. And it's really been a wonderful tool for us as we planned these operations. And so we not only use the models before surgery, but we use them in surgery. And so we have the models up on screens in the operating room, and they can really be a tremendous guide for the surgeon. And we've repurposed a Nintendo Switch controller. For those of you with children, you'll recognize this. And we use that as inside of a sterile bag on the operating field to sort of manipulate the model. We can look inside it and look at different features of the anatomy while we're doing the reconstruction, and it's really been an incredible step forward for us. We also can use the model as a guide for understanding more about the electrical system in the operating room. As Dr. Schidlow noted, there's a lot of variability in these patients and where their electrical system starts and runs. And when we're doing complex repairs inside the heart, there's a risk of injury to that electrical system. And so we've used the models as well as a specialized catheter inside the heart during surgery to identify where the electrical system runs, and that's been a huge help in reducing the risk to that electrical system during the operation. And so the repair inside the heart is often quite challenging in these patients, and so we've been able to use the 3D models as a tool to then plan how to create patches inside the heart or even vessels outside the heart, and so we can plan those patches out and take into account the different, both the geometry as well as the mechanical and material properties of the patch. So we can plan the patch size and shape out, and then we translate that patch into the operating room, and the surgeons can then use it as they do the repair. And so this has taken some of the guesswork out of these complex reconstructions, which has been really helpful and something we're continuing to build on. And this is an example of virtual surgery. This is a patient who is moving towards a fontan, and we are able to take the three-dimensional model, and you can see in blue the atria, or excuse me, the superior vena cava and the pulmonary arteries, and in teal the atrium. And with the 3D modeling and virtual surgery, we're able to plan out different fontan completion options, and so we can use the 3D models in that way. We can also use them to repair defects inside the heart. So Dr. Schidlow was talking about patients with narrowings below the valves leaving the heart, and how that can be quite challenging. So this patient has both a large hole between the two ventricles or pumping chambers of the heart. Here on the right, we're looking inside the right ventricle, shown in purple, and you can see through this large defect the orange left ventricle. This patient also has a muscular narrowing below the aortic valve, and so we can use these 3D models to both plan how to relieve that narrowing and close that hole with a patch. So here in green, you can see a patch that's been planned inside the heart to redirect the blood flow from the left ventricle completely to the aorta. And it's great to be able to sort of see it in its shape, but it's even more helpful as a surgeon to have the exact shape and plan. So we're able to pull that patch plan out of the model, and then we can really add dimensions to it, and then take it into the operating room with a system that we have to transfer that onto the sterile patch material, and that works incredibly well. So this has been a big step forward for us, and we're continuing to expand how widely this is used. This is the system that we use to transfer the patch design onto the sterile patch material. It's actually a very fancy laser pointer that projects the shape that we want the patch onto the sterile patch material in the operating room. So there's no guesswork involved, and we've shown that works very precisely. So less than 2% difference between the plan that we had and after that patch material is cut out with scissors, after we sort of trace out the shape on the patch. So this has been a really wonderful advancement to make these surgeries as reproducible as possible. And then in some patients, we need to go one step further and not only plan out different options, but then understand, okay, what would the flow be in these different surgical options? And this is particular for our single ventricle or fontan patients. And so we're able to use these 3D models and then plan different surgical options, and then using information from the individual patients about the flow and the pressure that's already in their heart from the MRI and catheterization procedures. We can analyze how we expect the flow to go through the heart and distribute to, for example, in this case, to the two lung vessels. And then we can use that information to select which is the best operative strategy for these patients before they go to the operating room. So then we go into the operating room with a very detailed plan knowing that that's going to be the right option for these patients. So this has been incredibly helpful in our most complex patients, where even with surgical and in cardiology experience, it's hard to be able to know exactly what the right thing to do is. And so when we do this flow modeling, we both model the flow under the conditions in which the child had the MRI and the cath, which most of them are under anesthesia, but then we also can scale those flows up to anticipate how those flows will be like under normal resting conditions, when the child exercises, and after they eat. And so we can get really a picture of how this will work for real life. And it's super important, and not just what it's going to look like for a child under anesthesia. And so this is an example of another complex Fontan patient, where they were going to go for a Fontan procedure, but it was unclear which was the best surgical option. This is a patient with heterotaxy who has 2 superior vena cava, and that variation that Dr. Schidlow showed, where there's a azygous vein that carries most of the blood flow back from the lower body to the heart. So in this particular patient, we were able to model different surgical options and then analyze the flow through them, and then look at how, in this case, the blood flow from the liver would go to both lungs. And one important aspect of being a Fontan is that there's some relatively balanced blood flow return from the liver to both lungs. And so we're able to look at different options. And in this case, this surgical option provided relatively balanced blood flow under normal resting conditions of 52% to the right lung and 48% to the left lung. Option C, which could have been considered if we didn't have this technique to analyze this, would have resulted in 100% of the hepatic blood flow to go to the left lung and none to the right lung. And that surely would have led to complications in the right lung in years down the line. So this has been a really helpful tool to avoid putting ourselves in a situation where complications could arise that could require another intervention. And so we've worked hard to validate these engineering approaches and using MRIs, and we've had very good agreement between our predictions by this flow modeling and what we've seen by MRI that's been very encouraging. And one other feature that is important in heterotaxy patients are the valve repairs that we often need to do as part of these reconstructions. And so we've developed an approach to create 3D models of the valves in these patients. We've done it over 60 patients, and we're in the process of advancing that work, and just show you a couple of examples of what that looks like. So this is a 3D model of a patient with heterotaxy who has a very complex valve. And what we're looking at here are 3 leaflets of one of the valves. You can see here in brown and yellow and in blue, the 3 different leaflets or components of the valves that will open. And we're able to create these detailed models that help us understand how the valve is not working perfectly, and then what steps need to be taken to repair the valve. And we can both look above the valve and then underneath the valve to see how the valves are supported. And this has really been very useful to have a detailed plan of how to reconstruct these valves in the operating room. So we have a big team at Boston Children's Hospital that supports the surgeons and the cardiologists that make these valves and do all this extra analysis. And it's been a super important part of caring for these complex heterotaxy patients. So this is my email, and happy to connect directly with any of you, and happy to take questions later.
So again, my name is Caitlin O'Connell. I am the nurse practitioner for the Heterotaxy Program at Boston Children's, and I'll be speaking to you about the rest of our program. So I thought I would start with, advance my slide, with our mission statement, which is that heterotaxy is a complex and multifaceted condition that affects multiple organ systems throughout the body. Therefore, the aim of our team is to provide comprehensive multidisciplinary care to infants and children with heterotaxy, including screening, management, intervention, and follow-up in order to optimize outcomes for these children. This slide illustrates the various aspects that make up a comprehensive heterotaxy evaluation. So Dr. Schidlow and Hoganson did such a nice job of reviewing the cardiac and cardiac surgical aspects of heterotaxy care. I'll turn our focus to the non-cardiac pieces, so that would include GI, general surgery, immunology, pulmonary, and genetics. As we talk about each of these subspecialties, I'll introduce you to our heterotaxy team members by photo, and then we'll talk about the manifestations that we can see with respect to each body system, as well as our approach to care. Due to our short time frame today, I'll just be giving a broad strokes overview of these subspecialties. As you all very well know, not one child with heterotaxy is like another. And for that reason, each child's care plan is going to look a little bit different. I am fortunate to be able to meet with every family that is referred to our program. After we do an extensive medical record review and a history with the family, I then work with our team members to develop an individualized care plan for that child. We will start off with GI, hepatology, and general surgery. So here in the top box here is Dr. Michaela Tracy. She is our general gastroenterologist on our team. Below her is Dr. Andrew Werman, who is a hepatologist, so a liver specialist on our team. And then the bottom photo is Dr. Ben Zendejas. He is the general surgeon on our team. So two of the things that we talk about most often when we're thinking about the GI tract and how it's impacted in children with heterotaxy is something called intestinal malrotation. So the two things that I'll be speaking about are actually illustrated here in the picture on the slide here. So intestinal malrotation is a disorder in which the intestines did not rotate properly during fetal development, and it results in an abnormal arrangement of the intestines. Why we worry about malrotation is because when the intestines are aligned like this, there can be a higher risk that the intestines can become blocked or twist upon themselves and become blocked, and that is a term called a volvulus. Biliary atresia is another thing that we talk about that impacts some children with heterotaxy. So that is a disorder in which the bile ducts are blocked or underdeveloped. This can cause bile to build up in the liver. In terms of our approach to care, first and foremost, with respect to intestinal malrotation, this can be a controversial topic in that the recommendations have kind of flip-flopped over the years, but the current recommendation from the scientific community is that routine screening for malrotation in children who are asymptomatic is not recommended. That is because, fortunately, most children with malrotation actually do just fine. We think that a lot of our children that have heterotaxy have malrotation, about 2/3 to 3/4, and many of them don't develop any GI-related problem. This is also because the procedure that can be done to correct malrotation is something called the LAD procedure, and that procedure in and of itself is not without risk. So we really have kind of turned the page and taken more of a conservative approach with respect to managing malrotation. That being said, part of my education that I go through with families routinely as part of our heterotaxy consultation is education about malrotation, whether or not their child has been screened for it, to know that there is a risk that their child has malrotation. And if that were to be the case, making sure that every family goes away from our consultation understanding what are the signs and symptoms of a volvulus. So I'm sure many of you know that would be bright green vomiting or bilious vomiting, abdominal pain, and abdominal distension. As for biliary atresia, we do routinely assess direct bilirubin for all of our newborns. That can be a marker for biliary atresia. If that were found to be abnormal, then we would refer to our colleagues in general surgery. In terms of immunology, the immunologist on our team is named Dr. Doug McDonald. So when we talk about the immune system in heterotaxy, we of course, talk about the spleen. So with that, Dr. Schidlow alluded to before, we see children that have multiple spleens or polysplenia or no spleen, called asplenia. There can be other immunodeficiencies that impact our children that have nothing to do with the spleen, we've learned over the years. And for this reason, it is our approach to perform a comprehensive immune evaluation. So this means that we do a lab workup that includes tests looking specifically for spleen function, as well as other tests that look at the broad immune system as a whole. For our patients at Children's, we're fortunate that we usually try to combine this lab assessment with other labs that a child needs, or perhaps during a procedure like a cardiac catheterization. If a child is having one of those, and we'll grab the labs at the same time. This is just in an effort to minimize extra blood draws for the kid. I think it's important to mention that the immune assessment really is meant to be not a one-time only evaluation, but is meant to be a periodic evaluation that occurs over time as the child grows and develops and receives their primary vaccine series. In the vast majority of cases, the child's immunologist becomes part of their lifelong team, just like the cardiologist, with periodic check-ins for some children yearly or for other children every couple of years through late childhood, just to make sure that things are on the right track. Another important feature of our immunology consultation that occurs is education about the proper infection prevention measures for our patients. So the three main paramounts of this would be antibiotic prophylaxis, what supplemental vaccines are needed, and then working with the family and the pediatricians to develop a fever plan. I'll just mention that, of course, our infection prevention measures are individualized to each patient depending on the results of the evaluation that they had. Next, we'll talk about pulmonary. So the pulmonologist on our team is Dr. Kenan Haver. He is a pulmonologist at Children's as well as a specialist in primary ciliary dyskinesia, or PCD. PCD is a well-known clinical entity that's called a ciliopathy. So basically what that means is that these cilia, which are specialized cells that line the respiratory tract, can become dysfunctional, and that can predispose to difficulty with our children clearing mucus from their lungs. This can predispose to conditions like pneumonia or frequent ear infections, sinus infection. There is another entity called heterotaxy-related ciliary dysfunction, which is an emerging topic that we're talking quite a lot about in the scientific community right now. And we think that that might be a more subtle form of ciliary dysfunction, in which children may not exhibit such severe features that those with PCD do, but they certainly can have difficulty managing secretions, particularly if they're under stress, such as after open heart surgery. So our approach on the heterotaxy team is to offer a PCD workup for every child that is screened through the program. So this includes nasal ciliary brushing to look at the cilia's structure. This is a procedure that I do, and we pair it when the children are already under anesthesia to minimize discomfort. We also offer nasal nitric oxide screening in our pulmonary clinic, which is a great test to screen for PCD, as well as genetic testing, which we're going to talk about next. And then another important factor in caring for these children is to optimize airway clearance. So we're actually about to launch an airway clearance regimen for all of our postoperative heterotaxy patients at Boston Children's to be used in the CICU and in the step-down units. That's really exciting. More to come on that. Last is genetics. So this is Dr. Amy Roberts. She is our cardiac geneticist on the team. Heterotaxy is a clinically and genetically heterogeneous condition, which means that there's not just one known inheritance pattern. It can be inherited as a single gene change and in a recessive fashion or a dominant fashion. Sometimes heterotaxy is associated with other syndromes like Down syndrome, but sometimes not. We do offer genetic testing to all children who are seen in the heterotaxy program. And that's for two main reasons. The first being that if we were to identify a genetic condition or genetic change, that explains heterotaxy, it may open our eyes to other body systems that we need to look into too. And the second main reason is so that we can provide reproductive counseling, both for the families of the affected child as well as the child themselves, for the future. If they know that they carry a genetic change that explains heterotaxy, that can be useful information down the line when they're planning their own family. Okay, so this is a map that shows all of the patients that have interacted with our program since May of 2022, which is when I joined the program. We're up to about 30 states now, which is really amazing, and I can't wait to see where the next few years take us. My next couple of slides are just dedicated to some resources. So this publication here, some of you may have seen, it was put out in 2022. Dr. Schidlow and one of our cardiac surgeons, Dr. Del Nido, took part in drafting this care guidelines paper, which really kind of does more of a deep dive and explains the approach to care that really mirrors our approach at the Boston Children's Hospital Heterotaxy Program. These two wonderful organizations I wanted to call out. So the Heterotaxy Research and Clinical Care Collaborative, or HRC3 for short, is a nationwide collaborative of physicians and scientists who are working together to understand more about heterotaxy and optimize outcomes for these children, as well as Heterotaxy Connection, which is a wonderful family support network and patient advocacy group. Both of these organizations have had wonderful conferences in the last 1 to 2 years. And I know that the links to both of those conferences are on their website. So definitely, if you're looking for more information, to take a deeper dive into any of these topics, those would be great resources. And then lastly, the Heterotaxy Program webpage on the Boston Children's Hospital website is another great resource. We have some patient education materials posted on there that we share with families, as well as some more general information. That is it for me. I actually included QR codes right here where you can link directly to the pamphlet. The pamphlets that I was just discussing on our webpage. This is our program email address and webpage address and our phone number if anybody wants to reach out. So I will go ahead and look for the questions. I actually got to, I think, stop my share to do that. Oh, and I guess I should say too that I know, as you guys know, this is being recorded and will be available as a link that is going to be sent out at the end, as well as, I guess, on the Boston Children's Hospital YouTube page. Okay, so here's a question. So basically, this is a person describing their 8-year-old that has polysplenia and a midline liver, who seems to have been discharged from care by the cardiologist and the GI team. But as the child grows, this family is wondering whether or not he needs a whole workup of his whole body. It looks like for 3 years, on and off, he's had some GI pains that was chalked up to constipation. Sounds like he had a LAD procedure as a newborn and has some intermittent stomach pain. Also does intermittently have complaints that his heart is beating too fast and that he needs to sit down and calm his body, but there's been no mention of a Holter monitor to work this up further. So I will hand that question over to Dr. Schidlow.
Yeah, thanks, Caitlin, and thanks also, Dr. Hoganson. Those were just terrific talks and a great overview of the program. Yeah, I think the question that was posed is really highlights some of the challenges with heterotaxy. Regrettably, we're not able to provide specific care for a specific patient on this webinar, but our approach, as Caitlin just pointed out, is to really do a comprehensive assessment of individuals with heterotaxy. And sometimes those are children with complex congenital heart problems, and Dr. Hoganson are talking quite a bit, but other times the heart is relatively normally put together, and the manifestations are really more non-cardiac in nature. So, while it sounds like that individual may benefit from being seen again by a gastroenterologist if there are ongoing issues, our approach, just like anyone else, would be to do a comprehensive assessment, including all of those elements that Caitlin, you just so nicely went over. So, Caitlin, if you don't mind, maybe I can pose a question that I've seen popping up quite a bit. Just recently, within the last year or so, you have started seeing families as part of our fetal care and surgery center and the program. And I'd be very interested to hear what that experience has been like from your perspective for these families and what benefit we can offer in the prenatal setting.
I would say that the consultations that I've been able to have with prenatal families has been really well received. As some of you on this webinar, I'm sure know, that early neonatal period can be a really overwhelming time for families. So I've received feedback that coming into that, period right after the baby's born, armed with information and being aware of what subspecialties will be coming by to meet the baby. Sometimes that's cardiology and cardiac surgery is at the forefront for those children that need surgery right away. And in other times where children are just being cared for in the newborn nursery. Again, the initial approach to care is going to look different depending on how heterotaxy has manifested in each child. But having a conversation before the baby's born, based on the information that we have during, that's been gathered during the fetal consultations, can be really helpful and kind of distill down the information into what each family really needs to know, and knowing that, engaging during the fetal period, and then it's kind of an ongoing relationship from there where we'll meet periodically to make sure that the kiddos are getting all the evaluations that they need. So I think, unfortunately, we did kind of run over time. So I know that there's a couple more questions in the chat, but we can definitely answer those offline. I just wanted to thank everybody for joining us. And again, you probably saw you can actually link right to our contact information right from the Heterotaxy Program webpage, because I know I wasn't able to share that slide for any longer. But thank you all for attending. Please look forward to that recording, and feel free to reach out with any other questions. Okay, bye. Thanks, everybody.
You.